those issues. Chris, from the perspective of, maybe you talk a little bit about patient burden and how we utilize an assessment of patient burden in our decision-making process about development of therapeutics.
Well, so as a type 1 diabetic of 35 years now, for at least the last 15 years, I've had roughly every 6 months or so assessments. And a wide range of assessments, from visual field to OCT and whatnot. And while I think those have been great to track the development of disease, what I think they lack is really a predictive potential and a capacity to tell me, they're prescriptive. They can tell me that I need to go on therapy, but they cannot tell me I should start intervening or provide any real guidance for what I can be doing now to prevent the development of disease down the road. So just in that regard, I think developing biomarkers that are obviously have meaningful endpoints, but are predictive of disease course, disease onset, and really guiding intervention, in my opinion, would be extraordinarily helpful and extraordinarily valuable. I guess another component is thinking about the likelihood of me having to undergo these therapies and these interventions down the road. What we currently have, particularly for kind of end-stage disease, seems to be very effective, but not without significant burden. Not just of cost, anti-VEGF injections are not cheap, but also side effects. Risk to my kidneys, which is another side effect of type 1 diabetes, is risk to the kidneys. And so is the therapy that is helping my vision or prevent loss of my vision impacting another component of my life negatively, and not to mention just the day-to-day burden of dealing with it all. I have to deal with managing my diabetes, going to the endocrinologist, all of that on top of just life. And do I want to take on something else, right? Yeah. that can prevent me from just living my life in an unburdened fashion. And so I guess I would really implore anyone who is thinking about intervention and developing interventions to really consider just the day-to-day impact as well as the burden that you're putting on someone that already has a lot of burden of disease management. Retinal disease is a disease of the eye, or at least diabetic retinal disease is a disease of the eye, but it's not because of the eye. It's because of the underlying disease. It's the diabetes that is driving it that has to be managed otherwise. And the eye is a primary loss of function, but not necessarily the primary one.